Oh, good morning, everyone. Myself, Prashant Matur. Today, I am going to discuss the topic on pathology of lobular carcinoma of breast. Here are the learning objectives. Learning objectives are define lobular carcinoma, understand epidemiology and risk factors, explain etiopathogenesis, describe gross and microscopic pathology, differentiate lobular carcinoma in situ and invasive lobular carcinoma, discuss molecular pathology and immunohistochemistry, understand prognosis, staging, and recent advances. First, coming to the introduction, definition of lobular carcinoma is it is a malignant epithelial tumor arising from the terminal duct lobular unit, that is TDLU. There are two major types are there. First one is lobular carcinoma in situ, invasive lobular carcinoma. It is the second most common invasive breast cancer, accounts for about 10 to 15% invasive breast cancers. Next, coming to the epidemiology, it affects mostly women greater than 50 years. The mean age is 50 to 65 years. It occurs in males rarely. It is usually hormone receptor positive. Higher incidence after menopause. Risk factors includes are family history, BRCA2 mutation, CDH1 mutation, hormone replacement therapy, increased estrogen exposure, previous lobular carcinoma in situ. Next, coming to the etiopathogenesis. The normal breast epithelium mutation occurs of CDH1 gene, then occurs loss of E cadherin, then occurs the loss of E cell adhesion, then it leads to single cell infiltration, then it leads to lobular carcinoma. Molecular changes are there, that are CDH1 mutation, PI3K pathway mutations, AKT mutation, HER2 amplification uncommon. Classification. Next, coming to the classification, World Health Organization classifies the lobular carcinoma in situ into five major types, that are classical carcinoma, classical lobular carcinoma in situ, pleomorphic lobular carcinoma in situ, florid lobular carcinoma in situ, invasive lobular carcinoma. Variants of invasive lobular carcinoma are there, that are classical, solid, alveolar, tubulolobular, pleomorphic, signet ring cell. Next, coming to the grass pathology, the grass features are like, unlike the intraductal carcinoma, these are poorly circumscribed, firm, gray white, diffuse infiltration, minimal dysplasia, difficult to identify grossly, may involve entire breast. Next, coming to the microscopy. The microscopy shows a hallmark feature like single file arrangement. Histology shows small, as you seen in the diagrams, there are small uniform cells. They contain round nuclei. Minimal pleomorphism is there. Infiltrate in Indian file pattern. Targetoid arrangement and around ducts. Intracytoplasmic mucin. Signet ring cells, minimal tubule formation, low mitotic activity. Characteristic histological patterns. Patterns are classical, that is single file cells, targetoid, that is tumor cells around ducts, alveolar, that is clusters of 20 cells, solids, sheets of tumor cells, pleomorphic, large atypical cells, that is uh, that is worse prognosis. Immunohistochemistry. Next, coming to the immunohistochemistry, there are certain markers which give positive or negative in certain cases. Next, look into the uh, marker and results. E cadherin gives negative, beta catenin negative membrane staining, ER positive, PR positive, HER2 usually negative, Ki67 low to moderate, GATA3 positive. Importance is loss of E cadherin compounds, lobular differentiation. Next, coming to the molecular features. Molecular features are intrinsic subtype, mostly luminal A, sometimes luminal B. Characteristics is ER positive, PR positive, HER2 negative, low Ki67. Clinical features, coming to the symptoms: painless breast lump, breast thickening, fullness, nipple retraction, occasionally occult lesion, difficult to detect mammography because of diffuse infiltrative growth. Spread. Next, coming to the spread, the spread occurs by local lymphatic blood spread or unique metastasis. Metastasis. So, coming local occurs by multifocal, multicentric. Lymph spreads through lymph nodes occurs by mainly by axillary lymph nodes. Spread occurs through blood hematogenesis or blood spread. The unique metastasis are there, that is peritoneum, retroperitoneum, JAT, that is gastrointestinal tract, ovary, uterus, leptomeninges. So next, coming to the diagnosis part, there are triple assessment is there. First one is the clinical examination. Okay, clinical examination. Then coming to imaging. In imaging, we have to exam breast by mammography or ultrasound, USG or MRI. Next, coming to the core needle biopsy, then histopathology, then immunohistochemistry. This is the triple assessment of diagnosis of lobular carcinoma of breast. Next, coming to the differential diagnosis. Invasive lobular carcinoma or intraductal carcinoma. There are some differences are there. Coming to the difference, in invasive lobular carcinoma, single cell cells are present. In intraductal carcinoma, glands are present. In invasive lobular carcinoma gives E cadherin test negative, whereas intraductal carcinoma gives E cadherin test positive. Diffuse growth is there in intralobular carcinoma. Mass lesion is there in intraductal carcinoma. Invasive lobular carcinoma is mostly multifocal. Intraductal carcinoma is usually solitary. In less desmoplasia in invasive lobular carcinoma, but marked desmoplasia or significant desmoplasia in uh, intraductal carcinoma. Next, coming to the treatment. So there are various options are available for treatment. First one is a surgery, breast conserving surgery, modified radical mastectomy, sentinel node biopsy, radiotherapy, hormonal therapy. In that, we have to give drugs like tamoxifen, aromatase inhibitors, chemotherapy, targeted therapy if HER2 is positive. These are the treatment options available for the uh, lobular carcinoma of breast. Next, coming to the prognosis. There are good prognostic factors are also present. Bad or poor prognostic factors are also present. Next, we will look after the good prognostic factors. That is, ER positive is if ER positive is present, then there will be the good chance of prognosis is there. Next, if PR positive is there, also good prognosis is present. Then low grade, then low Ki67 is present, then also good prognosis is there. Poor prognostic factors, pleomorphic variant, large tumor, nodal metastasis. If advanced stage is present or old age is present, prognosis is poor. 5 year of survival actually above the 5 years survival is rarely comparable or slightly better in than interactal in early stages. Key differences between lobular carcinoma in situ or intra invasive lobular carcinoma is there. Uh, uh, in lobular carcinoma in situ, this occurs in at sites. It does not have metastatic character. Whereas in invasive lobular carcinoma, it is invasive metastasized to different organs. Uh, Basement membrane intact in lobular carcinoma in situ, whereas basement membrane is breached in invasive lobular carcinoma. Lobular carcinoma in situ is a marker of risk, whereas invasive lobular carcinoma it is a malignant tumor. Usually incidental is invasive carcinoma of lobular carcinoma in situ, whereas invasive lobular carcinoma is a symptomatic. So this is seminar presentation. Thank you.